I'm actually tasked to confuse you, no, rather to address your confusion on a second common infection in pediatrics, and this is typhoid fever. So this is just my disclosure of interest. So for the next 30 minutes, I will be walking you through some general realities in typhoid fever, and then next would be addressing the challenge in the diagnosis and management of typhoid fever with a case scenario, and lastly, to discuss some preventive measures of typhoid. Okay, so we know that the cause of typhoid fever is Salmonella typhi. Then there's a lesser etiologic agent which is involved, and that would be Salmonella paratyphi. Now, because of the advent of, or the development of public health and a lot of development in sanitation, typhoid fever has actually virtually disappeared in the developed world. However, it remains to be endemic in developing countries like the Philippines and remains to be a global health problem. So in fact, if you look at this data, 90% of actually deaths of typhoid fever occur in Asia. Okay. So typhoid fever is common in this age group, from 3 to 19 years old, and humans are the only natural host and reservoir. Now, 2 to 5% of these people who are infected with typhoid fever become chronic carriers. Although in pediatrics, children have a little less risk of developing a chronic carrier state, around less than 2%. Now, what is unfortunate in typhoid fever nowadays is that Salmonella typhi has actually become increasingly resistant to the first-line antibiotics. But fortunately for the Philippines, maybe it's God sent, maybe because we don't have money, our resistance pattern remains to be low for the first line. So we will learn later what our first line agents would be. Okay. Now, as long as the infected person excretes Salmonella typhi, that person remains to be infective. And you are infective usually after the first week of illness until the time of convalescence. Not unless you become a chronic carrier, then you remain to be infective, and you are a source or a transmitter of disease. Now, typhoid fever, as we'll know, is actually transmitted via the fecal-oral route, more commonly through contaminated water and food. Now, one of the more common sources would be shellfish, so those who are fond of eating oysters, tahong mussels. Okay. Now, I got an infectious disease from eating shellfish. This is my experience from Bebot's region in Capiz. One of my very first lectures from oyster, but this is hepatitis A, not typhoid. Can you imagine? Infectious disease specialist coming down with hepatitis A. No vaccine. Kakahiya, no? But then, it was true. Bata pa po ako noon. That was like 10 years, 15 years. Wag na natin pag-usapan. Okay. But it's also true that flies can transmit the disease. Okay, so you have to really cover your cooked food with kahit niluto, but then there are a lot of flies flying around there, so pwede pa rin, you can still transmit, that flies can transmit the disease. Now, unlike rotavirus infections, yung rotavirus kasi, you get a very small inoculum, you eat it, then you get the disease. For typhoid fever, for Salmonella typhi, you need to eat a lot of the inoculum for you to come down with the disease. So for those people who are like matakaw like me, then you are at risk. So the dictum there, eat small quantities of each of the food so that you don't get that inoculum large enough for you to be developing the disease. Okay, this is actually Philippine data, 2013 from PIDSAR. It just shows us that, yes, indeed, typhoid fever occurs in all age groups in the country, but then again, it's most common in children 5 to 14 years old. But if you look at this data, what's sad is that the second most common group is really in the toddler age group, 1 to 4 years old. And they were saying in studies that If you get typhoid fever, salmonella typhi infection in this age group, then data would tell you that it is more dramatic, it is more toxic, you get a lot more diarrhea, you get a lot more complications, and mortality rate can be higher in this younger age group. Now, just to show you where the typhoid is, 2013, it's with Melba Masigan. Region 2 is Cagayan Valley, right? Oh, Region 2, these are confirmed typhoid cases. There was no explanation why it's in Cagayan during this time period, but we have to take note that, well, across time, the regions may vary. Like, for example, in this data, so year in, year out, typhoid fever remains to be constant in the country. So just showing you this data, 2014, we got 10,000. These are not confirmed cases. These are probable cases of typhoid. 2014, 10,500 something. 2015, you get a little bit more. No? So really, typhoid is here to stay in the country. And we do get outbreaks every now and then. Actually, year in, year out, there will be reports of outbreaks of typhoid fever. May it be post-disaster, it can be post-typhoon, but more commonly, you just get outbreaks anywhere in the country. Now, what's the advantage lang of a reported outbreak is that you get to know the source because they get to investigate. What makes it more difficult in diagnosing typhoid is that if it occurs in a non-epidemic occurrence, meaning what we usually see in clinical practice, yung paisa-isa lang. And that's where the difficulty will lie in terms of diagnosis. Okay. So, how do we define it? So what would be the standard case definition of typhoid? So a confirmed case is a patient with persistent fever, 38 degrees and over, lasting for 3 or more days with a laboratory-confirmed S. typhi organism. So it has to be culture. Okay. Or a clinical compatible case that is laboratory confirmed. Now, what is a probable case? This is usually what we get in clinical practice. Probable case, a patient with persistent fever, again, 38 degrees and over, lasting for 3 or more days with a positive serodiagnostic test. Or a clinical compatible case that is epidemiologically linked to a confirmed case or an outbreak. Then chronic carriers, of course, an individual excreting S. typhi in the stool or urine for longer than 1 year after that patient had the typhoid fever. Okay, so one reality is this: even the disease burden is difficult to estimate because the clinical picture may be non-specific, as I will be showing you later. It may be underestimated because you don't get to diagnose it in the first place, or it may be overestimated in such a way that if you get, for example, serodiagnostic test, turns out to be positive, you label immediately as typhoid. And that is usually what happens. I remember a case before, because this patient was a grandson of a laboratory technician. Okay, so just 5 or 6 days fever. Of course, the lola already did typhi, the serological test. Okay? Non-specific fever, headache, malaise. Okay. So turned out to be positive. Then, Doktora, can you admit naman may apo because may apo has typhoid fever? Eh si Doktora, sige, admitin natin. Sabi mo kasi, okay, fine. No? Okay. Following day, the patient had seizure. Buti na lang. Ibig sabihin, you didn't have to wait for that illness to evolve, but when the patient had seizure, of course, there's a neurological evaluation that has to be done. Turned out eventually to be TB meningitis. Okay, so, see, so that's how difficult it can be, even with laboratory examinations. It can be an overdiagnosis. Okay. So that difficulty usually occurs during the first week of illness, wherein your symptoms are actually non-specific in nature. These are generalized. You can think of any of the generalized infections, any febrile illnesses for that matter, because you wouldn't have yet those localizing features. And what's an added confusion, or what adds to the confusion is that, of course, when you think it's typhoid, when you think it's something which is bacterial, when you think of whatever, you get a leukocytosis in your CBC, what do? You start antibiotics, right? O talaga namang ganon. Umamin kayo. Diba? Oh. Okay, you start antibiotics. What will the antibiotics do? If it were not typhoid, it will just mask, it will just modify the evolution of the illness. So that adds up to the confusion. And then most of us, of course, we want a rapid diagnosis. We cannot afford to be waiting for cultures. So okay, zero diagnostic test kaagad. Turns out to be positive, treat as typhoid. Okay? Okay. So coming from those statements and thoughts, then we go to this case. Okay, this is our history. This is a 10-year-old boy who studies in a public elementary school in Quezon City, presenting to you with fever of 5 days, with a slight headache, vague abdominal pain with 1 episode of vomiting. Has also, in association with those symptoms, a mild dry cough with some nasal stuffiness. And then with anorexia or decrease in appetite. So there was no history of travel for this kid. Dun lang, pasok lang siya sa eskwelahan every day of his life. Okay. On physical examination, you have a high-grade fever, heart rate RR, blood pressure is in normal ranges. But this patient appears dry-looking with poor disposition, kind of weak-looking, but all others, clear breath sounds, so abdominal tenderness, normal heart, with just a slightly enlarged liver. Okay. So what would be your first impression? So 5-day history of fever, headache, vague abdominal pain, kind of weak looking. Okay. Who says it's dengue? Who says like you thought of dengue when you read the case? Just a show of hands. Oh, nga naman. Wala mang malit, walang tama. Hindi. Dami-dami. What about influenza? Anong yes or no? Hands or no hands? Yeah. Sabi ni Doktora Sally, yes. So, opo. Para matapos na daw. Teka lang po. Okay. What about typhoid? At this point in 5 days, fever, you thinking of typhoid? Oo, kasi typhoid yung lecture, di ba? No, but the dictum here is the often non-specific symptoms of typhoid fever can make its clinical diagnosis difficult. And it really can be confused with a lot of your acute, even subacute febrile illnesses, like malaria, dengue, influenza. So what can actually help us establish some clues in the diagnosis? So apart from that poor history, then we need to ask something else. Okay? So are there persons with similar symptomatology in the household? Okay, if it were like a toddler or younger child, is this child attending a daycare center? Yun mga kaklase ba niya, naka-diaper lahat? Yun mga yun. Now, what is the food preference or food history of this patient? Loves to eat street foods, always eat at home, always bring his baon in school. What is the water source? In most outbreaks, it's the water source which are actually the culprits. For example, pipes that are buried under a heap of garbage. Okay? And then, of course, identify the state of hygiene and sanitation and hygiene practices of the family and household members. And an exposure history, is there someone, a probable someone in the family who is actually, can be considered a chronic carrier? And of course, your travel history, is there any travel to an endemic area where typhoid is? Okay. Now, this is a table, okay, showing you the common clinical features of typhoid fever. So let's do like top 5, high-grade fever, coated tongue. Nakakita na po kayo ng coated tongue? Yeah? Okay? Yung parang dry na parang, diba? So coated tongue, anorexia, vomiting, hepatomegaly. Top 5 symptomatologies. It's very easy if you look at this table because it's all there. It's all there. What makes it difficult is that all these signs and symptoms do not occur together. They evolve. Okay? So they evolve. This one-shot deal here is okay. You have all the signs and symptoms of a typhoid fever patient. So what would be crucial now is timing, knowing the timing when these signs and symptoms actually occur. Okay? And so our question is, can typhoid now be diagnosed clinically when it matters? So can you diagnose typhoid during the first week of illness? Will you have that 100% confidence and say, hey, my patient, 10-year-old patient with 5-day history of fever has typhoid fever? Okay. Can you confidently say that? I think one of the things that can actually help us just a little bit to lessen the confusion is know the timing when the symptomatology occur. So these are symptoms of an untreated typhoid patient. If you look at week 1, so we go week 1, of course you have your non-specific signs and symptoms here. Okay, so high-grade fever, anorexia, chills. You may have a bit of a neurologic manifestation, like a malaise. Okay. Then you have your headache, your coated tongue. That patient can have mild cough during the first week. It's a very non-specific. No? And then just a bit of a GI symptomatology. But what is glaring from this first week of illnesses GI symptomatology, well, different from the other febrile illnesses, may be that of bloating. No, parang may kabag. Okay? So when you try to do PE, parang tympanitic abdomen. Okay? Although there's a vague abdominal pain. There can be also hepatomegaly. Okay? So that's week 1. Week 2, on top of your fever, on top of all your non-specific signs and symptoms, you start having now some neurologic manifestations. Neurologic meaning just a little bit more irritable, insomniac. Okay? Here, the psychosis occurs. Yun naman siya loko-loko talaga, no? Pero there are certain difference in terms of behavior. Okay? Siguro dahil may sakit, no? Medyo hindi na magandang pakiramdam. Now, week 2 also will show you, apart from bloating, for an older child or an adult, they can have more constipation. For a younger child, they can have more diarrhea. So week 2 will give you the non-specific signs and symptoms plus a little bit more of the neurologic manifestations plus a little bit more of the GI. So medyo naglo-localize na siya. Okay? Of course, week 3, if you're untreated, then you go GI perforation, etc. You go full-blown psychosis. You go typhoid state. I call it the tularemic state, typhoid state. Tularemic state because that patient can be tulala. Diba? That's your typhoid fasces, parang tulala. So my term there is the tularemic state. Okay. Now, what are the other clues in your diagnosis? Hey, so if you look at the temperature, but this is without giving antibiotics. Okay? Do not give antibiotics yet. So there can be rises, small rises in temperature elevation. Then you usually really reach a high-grade fever. Okay? Your fever will not be going down to normal. You still have that fever, but that temperature will peak in the afternoon. Okay, so hindi siya bababa, pero sa kataasan niya, tataas pa siya lalo when it's in the afternoon. Okay? So as mentioned earlier, constipation can be seen in older children, and then diarrhea is most commonly seen in the younger child. And diarrhea usually occurs in the second week. And this is if you see this is a classic description on how a diarrhea should be looking like. A typical diarrhea for typhoid fever. Really not diarrhea na 10, no. It's like 3-4 episodes of loose stool in a day, which is greenish pea soup in consistency. Okay. Your relative bradycardia, you're lucky if you have it. That would be for the adolescent and the adult. Okay. Now, in one study, with all the symptomatologies that I mentioned, it is only the fever or the duration of fever that was the only significant predictor for typhoid fever. So what does that mean? It's really very difficult to say on the 5th day of illness that, hey, I'm dealing with typhoid. If that fever goes on more than 7 days, then you can have a more likely probability and you have a lot more confidence. It's just duration of fever, okay, which is, again, the only significant predictor for typhoid fever. Now, other helpful clues in the diagnosis. If you have this, okay, so ito yung classic, toxic facies, coated tongue. There's a certain odor, musty, damp-like odor with a tender, doughy abdomen and an occasional low-level cough. Okay? Or, as mentioned, synthesizing everything, persistence of fever, usually more than 7 days, with GI changes, plus your neurologic manifestations. Okay? So that gives you a clue that you are dealing probably with a typhoid fever. Okay, now, the laboratory test. So you decided to admit this patient because you don't know what it is. So you got certain laboratory tests. So your laboratory tests came back. These are the results. Hemoglobin is 12, hematocrit is 38, WBC of 8, segmenter 60%, lymphocytes 40%, a platelet count of 150,000. You still thinking of dengue? 5 days pa lang naman yung lagnat. Pwede pa rin? Oo. Okay. Urinalysis, chest x-ray, normal. Typhoid dot is positive. And of course, you don't have yet your blood culture result. Okay. Typhoid na ba? Di pa. Kailan kaya siya magiging typhoid? Okay. So what now are the challenges? If you have challenges from the non-specific signs and symptoms, you also have challenges from the laboratory tests. So what will be these challenges? One, your gold standard for diagnosis is a blood culture, at least a blood culture. No? So blood culture is only positive in only 40 to 60% of cases. And the optimum time to get your blood culture is during the first week of illness. Okay. Now, for you to have that optimum isolation rate, then your specimen has to be collected adequately. That means a 10 to 15 ml of blood from your school children to adults and a 2 to 4 ml of blood from your toddlers and preschool children to have that optimum isolation rate. And then for stool and urine cultures, they become positive after the first week. Okay? And comparing to blood culture, the sensitivity is much lower. In most of the studies I've browsed through, stool culture is usually useful as a diagnostic test for chronic carriers. Now, bone marrow is really the most reliable one, but you don't want to do bone marrow in your patient. Okay? But if you don't have a choice, then you do it. But bone marrow is really invasive. But it's the most sensitive one. Okay. So just looking at this graph, so this is your blood culture. So first week of illness, you get around 80% positivity already, from blood culture. But if you look at the other diagnostic tests, even for zero diagnosis, then these would just start to go up or become positive at the end of the first week. And most of these diagnostic tests actually peak on the 3rd week of illness. Okay, so our favorite Widal test, how do we interpret it? Do we still have Widal test? Yes, no? You're still doing it? Well, okay. It's a serologic assay detecting both the antigens O and H, but only becomes positive on day 7 to 10. And of course, the more reliable interpretation would be a 4-fold rise. So you have to have that convalescent specimen at least 5 days after the first one. Or a single titer of more than 1 to 160. Okay? But the disadvantage really of a Widal test is really has both false positive and negative results. Okay? Now our favorite, Typhoid. They say that for a serodiagnostic test to be useful clinically in terms of interpretation, sensitivity and specificity must be more than 75%, meaning more than 75% sensitive, more than 75% specific, para useful siya. Okay? So if you look at these, I just got these 2 studies. Okay? So Typhoid for both Africa was the study used by WHO in their recommendation for the serodiagnostic tests. Okay? But we have our own Philippine study, so I put it here. So if you notice, both Typhoid.IgM and IgG, not more than 75%. No? So it's really not specific and not sensitive. Okay, so if in the Philippines, well, there's 2 Becks, okay, which in that particular study had a fairly good sensitivity and specificity. But again, what I'm driving at is you really have to also, apart from the serodiagnostic test, really have to really clinically correlate so that you can interpret it better. Okay, and not just take a serodiagnostic test as is or alone or a standalone as a tool for you to diagnose typhoid fever. Okay. Now, what about our favorites? CBC. Okay, well, usually you get a little bit of anemia, from typhoid, but looking at your WBC count, it can have a wide range. So blood leukocyte counts may often be low in relation to fever and toxicity because you would be imagining or you would be expecting a very high WBC count in a toxic patient. But in typhoid fever, it can be normal or it can be low. Okay. But then in infants or in younger children, leukocytosis may be a common association and can even reach the 20,000 range. Now, thrombocytopenia may be a marker of severe illness and may accompany DIC. Okay. Now, since you have a little bit of hepatomegaly, then if you want to do your liver function test, but liver function test is not dramatic. It can be a little bit deranged, but, well, hepatitis profile-like is very rare. Okay. So fever in this patient persists with occurrence of 3 to 4 episodes of loose stools per day. Now, patient became irritable. This time, you opted to treat as what? Typhoid naman siguro. Typhoid na lang kasi yun ang ating lecture. Okay. Typhoid fever. So what will now be, kasi you hurdled na diagnosis, you hurdled signs and symptoms, now you're on to treatment. Okay? So for this patient, okay, you've confidently say, I will treat as typhoid fever. So what will I be starting my patient with? Okay, so again, show of hands, lang natin, what your practice is. Who would be starting this patient on chloramphenicol? Kunti-kunti lang. Okay. Ay, sorry. Ceftriaxone. Ceftriaxone, mayayaman kayo talaga. Okay. Kasi you can afford PHP. Okay. Cefixim. Ana. Si Ana dapat diniscuss si typhoid para made my life easier. Okay. Ciprofloxacin. Okay. In all infections, we always say that we have to look at our local epidemiology to tell us the appropriate antibiotics that we will be using to our patients or that we will be administering to our patients. It's always go back to the local epidemiology. What do we have in the country? Even if the whole world is resistant, okay? Because WHO revolutionized it. Because a lot of countries, even countries in Southeast Asia, are resistant already to the first liners. But it's always important to look back at what we have in the country. So what do we have? Ampicillin is 2.9% resistance. Kotrai is 6.7%. Nalidixic acid is 8.9%. Chloramphenicol and ciprofloxacin, 0%. Okay. I don't know if you can see this. I cannot because I do not have my glasses, but I will look. Okay. Okay. Why did WHO actually recommend such? Fully sensitive, first line is fluoroquinolone. Why? Because this is what is being mirrored in most of the countries globally. Okay? But of course, for fully sensitive, there is still that alternative effective treatment, which is your first line. Now, for multi-drug resistance, it still is fluoroquinolone or your third-generation oral cephalosporin. This is for uncomplicated typhoid fever. And then for quinolone resistance, it would be your macrolide azithromycin or your ceftriaxone. If you look at your third generation, just a word on the third generation parenteral or ceftriaxone. How long do we usually give ceftriaxone in patients with typhoid? Sabi ni David Isaacs, right? Multiple of 5s or 7s, right? So 5 days, 7 days, 10 days, 14 days. Sobra na kayo, ha? 1 month? Okay. So, in actuality, in literature, there is really no actual recommendation on the duration of treatment for your third generation. Just a word of it. Third generation cephalosporin. Now, studies have shown that a 7-day ceftriaxone treatment will still have a higher relapse rate of around 14% for children 3 to 4 weeks after the infection. Okay, so 14% relapse rate. That's why if you look at certain guidelines, do not be shocked or surprised if the duration of treatment for your third generation IV cephalosporins can be as long as 10 to 14 days. Okay. Okay. Now, just to simplify it, this is what we follow. No? Actually, we follow FIGAN. It's our Bible in infectious disease. Okay. So for the fully susceptible typhoid, Salmonella typhi. So first liners will still be your chloramphenicol, Amox or trimethoprim sulfa, and then with their corresponding doses and days of treatment, or your third generation oral cephalosporin or your quinolone. So for the Philippines, we can still do or administer our first line, which is chloramphenicol, based on our local epidemiology. Okay. Multi-drug resistant, then you go azithromycin, a third generation cephalosporin, or a fluoroquinolone. Then for quinolone resistant, then you just, again, have those antibiotics, azithromycin, third generation, parenteral now, and oral cephalosporin. Again, with their corresponding doses and durations. Okay. Now, what you need to know is that it's not magic. As Anna mentioned in her lecture earlier, the effervescence time is 7 days. You usually get clinical improvement in 3 to 5 days' time. So it's not like, you will explain, within 48 hours, I will see the effect. No, you may not in typhoid fever. You have to be patient enough to look for the clinical improvement in 3 to 5 days and actual effervescence up to 7 days. But they say that in some studies, like if you use, like for example, a quinolone, then you have an earlier on effervescence, can be as short as 3.3 to 4.2 days with lower relapse rates. Okay. Now, because of the resistance that they see, this is the last leg of the lecture, the resistance that they see across worldwide, okay, the importance of vaccination and other preventive measures for typhoid fever is heightened. Okay. And what would now be, or what would be the available vaccines? Okay. There are 2 vaccines available in the country, recommended for use. We have your injectable polysaccharide vaccine for persons or for children 2 years and over, and we still have that oral TY21A vaccine recommended for children over 5 years. Okay. Now, what will be WHO telling us? Okay. So, WHO says countries should consider the programmatic use of typhoid vaccines for controlling endemic disease. So it would still be a country recommendation. What do you have in your country? Okay. But most countries, control will require vaccination only for high groups, okay, or special populations. But during outbreak control, or during an epidemic or an outbreak, then vaccination may be recommended for outbreak control. Okay. Now, in some countries where there is really a high burden for school-aged children and where antibiotic resistance is really prevalent, then you may opt to give your typhoid vaccine. But of course, it's recommended for travelers, especially travelers going to endemic areas. Now, all these recommendations, all typhoid fever vaccination programs should be implemented in the context of other efforts to control the disease. So it's not a vaccine stand-alone thing. It has to be together with other preventive measures such as health education, water quality sanitation improvements, and of course, training of health professionals in diagnosis and treatment of the disease. Okay. So this is what we have. 2015, you will have your 2016 recommendations later on, but 2015, typhoid vaccine is a vaccine for special groups. Okay, so given at the minimum age of 2 years old with a revaccination every 2 to 3 years, and our recommendation is for travelers to areas where there is a risk of exposure and for outbreak scenarios, for control of outbreaks. Just a last word. I know you know this, but do you do it? Just so you start doing it. Okay, hand washing with soap and running water, eat food that has been thoroughly cooked, ensure that the cooked food is covered. Remember, flies can transmit it. Avoid raw vegetables and fruits that cannot be peeled. If you cannot peel it yourself, then you don't eat it. Avoid food and beverages from street vendors. Sarap ang fish ball. Okay. Boil drinking water at least 1 minute. Ask for drinks without ice. Okay. I want bottled water. But you ask naman, but I want iced tea. Ganon din. No, because you're using the water to dilute the powder of the tea. So avoid flavored ice and juice. And of course, properly refrigerate your food when possible. Okay. So just to summarize, 3 points. So typhoid remains to be a public health concern, especially in developing countries like the Philippines. And because of the non-specificity of initial signs and symptoms, also of laboratory exams and diagnosis may be confusing and may be difficult at the onset. And prevention through immunization is, of course, largely dependent on the epidemiology of the disease in the country. Okay, so with that, thank you very much and enjoy the rest of the conference.
For our next lecturer, we will now call on Dr.